the first intervention occurred with biopsy. So endoscopy started as a purely diagnostic tool, allowing us to look at the mucosa of the GI tract. But it evolved into an interventional tool with the integration of that working channel into the endoscope, allowing us to perform biopsies. Now that was, of course, still diagnosis. And now we make the shift to therapy. And this has really been the stage over the past decades, the development of therapeutic accessories. And you can see there is a wide array of accessories that we now have available to us. They're all shown here on the left. Allows us to extract, to inject, to cut, coagulate, dilate, ligate, and stent. These are all the possibilities that have blossomed over such a short period of time. And we can actually group this array of therapeutic interventions into three categories. And the first is polypectomy. The second is unclogging the lumen. And the third is stopping bleeding. Now let's start with polypectomy. Now this is a procedure that has really not changed since Shinya invented the snare and the procedure back in 1969. And here you can see some of his sketches of his invention on a memo pad. This is the snare, and it really hasn't changed much since he invented it. It's also the poster child for what makes flexible endoscopy great. A very clever, simple tool. But what amazing capabilities. Now, unclogging the lumen. This has been an area of tremendous growth and innovation. We have a large array of devices, and the choice of tool depends on the nature of the obstruction and the site of the obstruction. So we can extract, be it a foreign body in the esophagus or a stone in the bile duct, using balloons and baskets and nets. We can dilate using bougies or non-compliant balloons. We can ablate using thermal modalities. We once used very high-tech things like laser. Now it's been supplanted by more user-friendly modalities like argon plasma coagulation. And then we have very clever ways of combining drugs and devices to perform, for example, photodynamic therapy, where we can minimize the collateral damage. What about stenting? Well, that really started as almost a barbaric side note of endoscopy. These plastic rigid tubes had to be placed with general anesthesia with high complication rates. Well, that all changed dramatically with the invention of the self-expandable metal stent. Stopping bleeding. We can coagulate using various thermal modalities. They can be contact and they can be non-contact. We can inject. It can be non-variceal bleeding, like an ulcer. It can be variceal bleeding. And this has been a very exciting area of development. Manual or mechanical methods of hemostasis. We can ligate using bands, clips, and loops. Now, what do all of these procedures have in common? They have 4 key ingredients. They are simple, they are easy, they are quick, and they are effective. We're talking about simple tools. Clever, but simple. The deployment is easy. You don't have to take a specialized training course to do the procedure. And it can be done by a single operator. It's a quick procedure. It can be done in the span of 20 to 30 minutes. And the results are effective. And also effective are the costs. It's cost effective. Now, the indications for therapeutic endoscopy historically has been what I call the 3 Ps. Prevention, that's exemplified by polypectomy, prevent cancer. Palliation, that's exemplified by stenting, to open up that obstructed lumen by cancer. And the prohibitive risk patient, the patient who's high risk for surgery, and so endoscopic treatment is the next best choice. But a paradigm shift occurred in the 1990s 90s. A shift from the concept of therapeutic endoscopy, which was promoting a lesser invasive alternative to surgery, to endosurgery. That's using the endoscope as a tool to actually perform surgery. It's also a shift from a concept of complementary to surgery to competitive with surgery. Paul Swain reported back in 1986 on one of his inventions, his many inventions, the endoscopic sewing machine, and he wrote, "It will enable endoscopists to perform a range of new internal surgical procedures without having to make an external incision in the patient." We're talking about the endoscopist becoming a surgeon with the capability of stitching. Now, it took 15 years for his device to get FDA approved, but it opened the floodgates, literally opened the floodgates for a whole array of new endosurgical devices capable of stitching, and even the bottom two capable of stapling. Surgical tools in our hands. And of course, if we can do surgery in the gut lumen, then why not take it outside of the gut and do surgery in the peritoneal space, laparoscopic surgery? Why not do a cholecystectomy or appendectomy? That's notes. So there was a natural evolution to notes. But then, when all of this new technology actually entered the clinical arena, the doctor started to use these tools. We found that these were really very complex tools. They're difficult to deploy. They required specialized training. There were prolonged procedures, an hour or more, with the general anesthesiologist usually. And the efficacy was uncertain, and it's because the playing field had changed. The rules are different for a competitive procedure compared to a complementary procedure. What a far cry from the days of simple, easy, quick, and effective. We also saw the challenge of notes as soon as that was done in patients. The endoscope was insuted in the peritoneal space. It was floppy. There's no triangulation. It's a small channel, uncontrolled insufflation. Our tools, of course, the device manufacturing companies were developing new tools by the day, but they were still a far cry from the laparoscopic equivalents. Remember, it took over 3 decades to develop laparoscopic tools. Training issues. The surgical and the gastrointestinal endoscopists are really 2 different breeds. They have different skill sets. And then there was a little bit of bait and switch here. It wasn't really a pure notes after all. It required an accessory laparoscopic port, and that highlighted the limitation of notes, but it also diminished the attractivity of notes. And it's really against this background that I want you to understand why we, the interventional endoscopists, have started to look back at our own roots. Actually look into our own backyard rather than the surgeon's backyard. See, endoscopic ultrasonography has been with us since the 1980s. It's our eyes to see the outside world. We have been visualizing all of the organs around us for decades. You can see here with the endoscope position in the upper stomach, we can see the liver and the spleen and pancreas, kidney. And just as endoscopy evolved from diagnostic to interventional, EUS also evolved with the ability to do F&A to an interventional procedure. And we can pass our needle through the working channel, and we can guide that needle very precisely with high resolution into our target organ, whether it's a neighboring organ like pancreas or liver, or lymph nodes, or a periintestinal mass, or fluid collection. F&A then quickly evolved to a therapeutic procedure with F&I, using the same fine needle injection, using the same needle. So rather than aspirating fluid, let's inject a fluid, a substance, a pharmaceutical. So we can perform celiac blocks. We can perform tumor therapy by injecting chemotherapeutic agents or immune reactive agents. Lots of exciting therapeutic possibilities. We could also implant, rather than inject, implant a device through that very same needle. It could be a radiation seed for brachytherapy. It could be an RF electrode. We heard a little bit about that today for tumor or tissue ablation, a laser probe for photodynamic therapy or tumor ablation, or even just a fiducial to assist in radiation therapy. That device could also be a wire. And if you pass a wire through the needle, then you've got the Seldinger technique, which allows us to use the wire as a scaffold to introduce other therapeutic devices. Pseudocyst drainage, EUS-guided pseudocyst drainage, is really our best example of the Seldinger technique. Using a large bore needle, we puncture and access the pseudocyst, we place a wire into the pseudocyst, we remove the needle, we dilate the tract with a balloon catheter, and then we place stents to drain the pseudocyst. What an elegant procedure, all done internally. And of course, it's not just pathologic fluid collections that we can drain, but it could also be a fluid-filled organ, like the gallbladder or the urinary bladder. And we can drain any fluid collection surrounding any part of the GI tract. Remember, the GI tract starts up here, so mediastinum, abdomen, pelvis. It's really our window to the entire body. EUS is so unique because it allows us to obtain these incredibly detailed views of the pancreas and the extrahepatic biliary tract. You can see why we think, the endosonographers, that the GI tract was created, the upper GI tract, for endosonography of the pancreas and the biliary tract, and digestion is just sort of a little bonus function. In 1996, EUS converged with ERCP, and that's when the first EUS-guided ductography was performed. Dr. Wiersma injected contrast directly transenteral through the stomach into the bile duct, and he produced a cholangiogram. In 2001, the first bile duct drainage was performed under EUS guidance, and in 2002, the first pancreatic duct drainage. What is evolving is something that I call EACP, EUS-guided anterograde cholangiopancreatography, where we can access the bile duct, not retrogradely, ERCP, but anterogradely, and we can drain the bile duct, such as shown here, transgastrically, or the pancreatic duct. Just to give you a flavor of what the procedure looks like, this would be a patient with a Klatskin cholangiocarcinoma. ERCP was attempted and failed. We couldn't get our wires upstream from the obstruction. So you can see that the needle has been passed transgastrically into the left hepatic duct. We aspirate some bile to confirm that we're inside of the bile duct. We're now injecting contrast into the duct. We get a cholangiogram. We pass a guide wire. That is our scaffold now to dilate the tract with a bougie. You can see the bougie passing over the wire, dilating the tract, and now we have primed the tract for stent drainage. So you can see both on fluoroscopy and on endoscopy how the stent is placed to drain this bile duct now transhepatic, transgastric into the stomach lumen. Now this is a compilation of some of the results that have been reported. It's still a very young field. As you can see, there have been maybe slightly over 100 cases that have been reported. The success rates have been remarkably good, in the order of 90%. Now there have been complications, of course. This is an evolving technology. And I'm going to highlight this in just a moment, but this is where we need better tools, because we need to reduce that complication rate. The question that arises as this disseminates is whether EACP will one day replace ERCP. Will the anterograde approach replace the retrograde? Well, we eliminate difficult cannulation. There is no risk of pancreatitis. That's an important one. That's, of course, our nemesis has always been the risk of pancreatitis. We're working above the pancreas. We don't touch the pancreas. There is no instrumentation of the stricture. The Japanese have always argued that every time you manipulate a cancer and pass instruments through it, you may disseminate or seed cancer cells. We eliminate that. But most importantly, could this be the holy grail we've been searching for, the solution to stent clogging? Well, possibly, but before that happens, what we need are devices designed for EUS-guided transluminal therapy. These are devices that are well visualized on EUS. See, the focus has been on ERCP devices, well visualized on fluoroscopy. They need to be seen well on EUS. It's EUS-guided. It needs to be easily deployed through an echo endoscope, not the duodenoscope, the echo endoscope. It should be exchange-free, and it should provide all-in-one delivery platforms. We should eliminate the many steps. You see, we're using off-the-shelf tools now to do these procedures. That's why it's so challenging and time-consuming, and why our complication rates are still unacceptably high. And it must provide robust lumen-to-lumen apposition to prevent leakage. I predict that in the next decade, we are going to see enormous development in this arena, development of specialized EUS accessories. So in conclusion, let's remember the historical ingredients to successful therapeutic endoscopy. Remember, simple, easy, quick, and of course, effective. There has been a paradigm shift to endosurgery, as well as notes, and notes is here to stay. The surgeons will continue to develop notes, there's no question. But that shift has been slow and has been fraught with many challenges, especially for the gastrointestinal endoscopists. EUS opens up new frontiers for therapeutic transluminal therapy. That's the new frontier. FNI for delivery of drugs and devices. We can drain fluid collections and drain fluid-filled organs like the gallbladder. There's a convergence with ERCP for ductal drainage, EACP, and we have the ability to actually create surgical-like anastomoses such as gastric bypass.